for tuning in. I have nothing to disclose. I was asked to speak about my pathway to stewardship and how stewardship plays a role in my job in public health. In doing so, I hope I'll inspire some of you to think about working in public health, and if not working in public health, then to collaborate with public health at some point in your career. This slide shows the outline for what I'm going to talk about today. I'll start with a little background about me, talk about the complicated epidemiology of antibiotic resistance, and how we at the Washington State Department of Health work to combat antibiotic resistance.
Oh, that's cool.
My path to my current position was certainly not a straight line. My parents were both social workers, and I was raised with an understanding that one's work should help people. As an undergraduate, I was disturbed when I learned that the infant mortality at one end of the rapid transit line was more than 2 times higher than at the other end. And I wondered how we as a society could fail to correct such inequity. I went to medical school and trained as a pediatrician because pediatrics is all about prevention, but saw quickly that healthcare comes too late in many cases, and that social determinants of health, where you live, learn, work, and play, are even more important than healthcare for improving population health. So that's how I ended up in public health. I wanted to help more than one person at a time, and I wanted to get at the root of health problems. I got a master's in public health and epidemiology at University of Washington and joined the Washington State Department of Health in 2009. When the state epidemiologist left the department in 2011, I was asked to fill in on his healthcare-associated infections work. And all of a sudden, I started getting calls and questions from labs and local health departments about unusually resistant bacteria. Around this time, the first Verona integron-encoded metallo-beta-lactamase that was identified in the United States was reported in Washington State in someone who had had health care in Greece. A little later, a young man suffered a traumatic amputation in India and returned to Washington with an infection involving several different genera of Enterobacteriaceae, all carrying New Delhi metallo-beta-lactamase. We also started getting reports of Klebsiella pneumoniae carbapentamases, our U.S. homegrown carbapentamase. And these reports were in people who had not had health care outside of Washington, suggesting that they were actually acquiring it in Washington healthcare facilities. This led to a steep learning curve about antibiotic resistance and preventing healthcare-associated transmission of multi-drug resistant organisms. Currently, I am funded by U.S. Centers for Disease Control to serve as the antibiotic resistance and stewardship expert for the department's healthcare-associated infections program. And I'm lucky to say my job is really interesting. My work focuses on 3 main areas: investigating targeted multi-drug resistant infections, supporting best practices in infection prevention to prevent transmission of these organisms, and promoting antimicrobial stewardship with an overall goal of combating antibiotic resistance. Antibiotic resistance is very complicated, as this figure demonstrates. It shows the movement of antibiotics and antibiotic-resistant bacteria in and between people, animals, and the environment. We think about unnecessary antibiotic use in humans as being the key driver of antibiotic resistance, but it's much more complicated than that. All antibiotic use promotes antibiotic resistance. necessary and unnecessary, appropriate and inappropriate, and includes the antibiotics that are used in humans and pets, in farm animals, in aquaculture, on agricultural crops, and in household products. Most of you will focus on improving antibiotic use in humans, but I hope that you will also be aware of other uses of antibiotics and areas where that use can be improved. This is a picture of Kibera, a large slum on the outskirts of Nairobi in Kenya. So in the US and in other high-income countries, we think in general that less antibiotic use is better. But in some parts of the world where healthcare and resources and sanitation are limited, they actually need more antibiotics, more expertise, and help getting antibiotics to the right place. In Washington, we based our state program on leadership from the White House and from Centers for Disease Control, and followed guidance in the National Strategy and Action Plan for Combating Antibiotic-Resistant Bacteria, and we received federal funding to do this work. We identified 5 main strategies to approach the problem of antibiotic resistance, which are detect, protect, prevent, innovate, and collaborate. Detect means we perform surveillance and use advanced lab diagnostics to identify emerging resistance. Our state has one of the 7 CDC antibiotic resistance labs in the US to do this work. Protect means we quickly investigate and respond to resistant organisms to prevent transmission, and also by improving overall infection prevention. Prevent means we try to minimize selective pressure for antibiotic resistance by improving antibiotic use. Innovate means we support development of new, faster diagnostic tests, new antibiotics, and new ways of improving infection prevention. And collaborate means we work with partners in Washington and in other states and also at the national level who are also combating antibiotic resistance. Recognizing that antibiotic use in humans is only one piece of the antibiotic resistance puzzle, our overarching goal was to have a One Health perspective by also considering the importance of antibiotic use in animals and crops, biosecurity in animal agriculture, and environmental contamination with antibiotics and with antibiotic-resistant organisms. We all know that microbes don't respect borders, so to have a meaningful impact, we as a nation need to promote global coordination and cooperation on combating antibiotic resistance. We support and promote CDC core elements of stewardship, which include hospital leadership commitment, accountability, expertise, taking one or more actions to improve antibiotic use, tracking and reporting, and education. We develop materials and resources to help hospitals, long-term care, and outpatient facilities establish and improve their stewardship programs. We believe that measurement of antibiotic use is essential to know what antibiotics are being used, where they are being used, how much, for what indication, and prescribed by whom. We'd really like to know this information everywhere antibiotics are used, inpatient, outpatient, by vets, on farms, etc., but we had to start with a realistic goal. And that was to encourage hospitals to report their antibiotic use so that it can be tracked internally and also for benchmarking between hospitals. The goal is for all hospitals across the country to report into the National Healthcare Safety Network antibiotic use module. Likewise, we'd like to have timely outpatient antibiotic prescribing information. Currently, an organization called IQVIA collects very complete antibiotic prescribing data, and CDC presents this on their website and also shares the data with state public health. This is the IQVIA outpatient antibiotic prescribing rate by state. This is from the CDC website. And you will see that there is really wide variation in antibiotic use across the United States, from a low in Alaska of 462 prescriptions per thousand population to a high in West Virginia of 1,197 prescriptions per thousand population. And this variation suggests that there is vast room for improvement. This is another example of data from IQVIA. This is the number of outpatient antibiotic prescriptions written by physician assistants who are in the top 10% of prescribers, meaning that they prescribe the most antibiotics in the state. And I'm not trying to pick on PAs. The curves look almost identical for all the provider types that we receive data for, which includes family practice physicians, internal medicine, emergency medicine, pediatrics, dentists, physician assistants, and nurse practitioners. As you can see, there is a moderate increase going from the 90th percentile to the 99th, and then this exponential increase from the 99th percentile on up, again suggesting that there is overuse and inappropriate use of antibiotics. And this is from one of our in-state data sources on hospital antibiotic use. And it shows overall antibiotic use in days of therapy per 1,000 patient days in different categories of hospital size, from critical access hospitals on the left to large hospitals with more than 250 beds on the right. And as you can see, within each category, there's a wide variation in antibiotic use rates, from a low of about 20 days of therapy per 1,000 to close to 80 days of therapy per 1,000 patient days. Basically, what I want to emphasize by showing this variation in antibiotic use in all these examples is that antibiotic stewardship is essential, and that we need to measure use in order to be able to assess the effectiveness of stewardship efforts and to educate those with high antibiotic use that they are outliers. In Washington, we were able to provide a little bit of funding to our partners at the University of Washington to implement the Mitigate Antimicrobial Stewardship Toolkit in outpatient clinics. And some of their results will be presented in abstracts at this conference. So I encourage you to look for abstracts by Zara Casamali Escobar and also by Joanne Wong. We also provided funding to the same group to help them get their tele-antimicrobial stewardship program started. This program provides virtual education and case discussion for almost half of Washington hospitals, and also for many hospitals in the western part of the United States. Other than stewardship, another main focus in our program is improving infection prevention in all healthcare settings. As I got more involved in the HAI program, I was shocked to learn how little infection prevention education is provided to healthcare providers in training, and how few IP resources are required in many healthcare settings, particularly in those that provide care to the elderly. A huge part of our program is to improve infection prevention, and one way we do this is by going on site when these multi-drug resistant organisms are identified to assess practices and offer support for improving their programs. Our program does a lot more than what I've described today. I wanted to cover the enormity of the antibiotic resistance problem and also some discrete areas where you, as ID experts, can make a real difference, and to emphasize that if we do nothing, the problem will only get worse. Finally, I'd like to close with some good news. This just arrived in my inbox on Friday. The federal government just published an updated national action plan for combating antibiotic-resistant bacteria and committed to increased funding to fight antibiotic resistance. That's the end of my presentation. Thank you so much for listening in, and I welcome any comments or questions from you.